So we're going to talk next about the post-term infant. We've talked a lot about the baby that's born preterm. What happens if we go past 42 weeks? First of all, post-term is defined as delivery after 42 weeks. What does that baby look like? Well, they've rubbed off all the lanugo, so they don't have a lot of it left. They may not have a lot of vernix left, that white cheesy stuff that's in the creases. They may have more scalp hair than a typical newborn. Their skin may be cracked and already peeling, which remember that after birth, the baby peels usually a few days later. A post-term baby may be born already peeling. They may have a wasted appearance. Sometimes they look like little old people because they've grown, but they may have used up their brown fat and their subcutaneous fat and possibly even started to break down some muscle for survival because the placenta is aging. They're also more likely to have passed meconium in utero, so they may have meconium staining. Complications of post-maturity. Once the baby is out, then we're really just looking at, did they have a complication? One of the major complications of delivery is they don't tolerate contractions because the placenta just cannot oxygenate them adequately. So this baby is more likely to be have fetal distress during labor and or to have instrumental or cesarean delivery because of fetal distress. They also are more likely to pass meconium, and anytime meconium is passed in utero, there's a risk of meconium aspiration. We're going to talk about that as a separate complication later, but you need to know that one of the risk factors is post-maturity. What does this look like? There's meconium in the amniotic fluid, but if they aspirate it into the lungs, it actually blocks the alveoli, clogs them up, it causes inflammation, causes swelling, so it impairs gas exchange. Okay, so what does it look like? Tachypnea, they're breathing too fast, they may be hypoxic, they may have acidosis. Early on, they may have hyperventilation, they're trying to breathe deeper. Later on, they have hypoventilation, their lung tissue has swollen and they can't get air in. What does this look like? At birth, if there is meconium present at birth, we want to use a bulb syringe and suction the mouth and then the nose. Always do mouth first, then nose. It's alphabetical order. Also think about, do you want something stuck in your nose and then in your mouth? You'd rather do it the other way around. So mouth first, then nose. If the baby is vigorous, if they're like trying to breathe and move and all those things, we don't suction the trachea, we just observe them. If they require resuscitation before they start to ventilate, they need to try to suction out as much of that meconium as they can get quickly. And then we monitor that baby. If there was meconium, we monitor for respiratory distress and provide supportive care. If they have meconium aspiration syndrome, surfactant can help decrease the surface tension in the alveoli, so it can help them keep their lungs inflated. Inhaled nitrous oxide dilates the pulmonary vessels. If it's severe, they may use ECMO. Some other things that may happen with a post-term baby, they may have hypoglycemia because they also store glucose in the liver as glycogen during the last few weeks of pregnancy. But when the placenta starts to give up, they start to use that. And so they may have used their glucose reserves and they may have hypoglycemia and they may have hypothermia. Sometimes we forget to watch for that because they look big. So we're thinking big baby, they can stay warm. But if they've used up their brown fat and subcutaneous fat in utero, they're more at risk for hypothermia. The next section is going to be about babies that are smaller or larger than they should be for their gestational age.